Maddie, how's that look?
Perfect.
Perfection. I always get messed up too with what buttons to use. So for those of you who don't know me, Maddie said I wear a lot of hats. I work full-time for oncolink.org, which is a cancer education website here at the University of Pennsylvania. I've been there full-time for about 6.5 years. And all I do is education, patient education in this psychosocial insurance, financial navigation, coping, survivorship, you name it, that's what I do. In my part-time, I work for the cancer support community as the financial navigation specialist for their helpline and also as a helpline navigator. And Maggie mentioned, I also have students that I work with and my two amazing therapy dogs, Linus and Huck, who some of you maybe we've met in radiation oncology at Penn, or maybe we'll meet with you in the future when we're back to doing our work. So I like to start this talk off with just making sure we're all on the same page about what is insurance. Just a really brief overview that insurance is essentially a financial protection against medical expenses if you have an accident or major illness. Now, I do give a little caveat there because accident regarding some sort of automobile oftentimes gets kicked back to your automobile or the automobile insurance of the persons you're involved in accidents with, but it's the same sort of premise, right? It's financial protection against injury and to help us deal with losses related to that. It's a contract between you, who are the insured, and the insurance company. And this is particularly important for those of you who might be thinking about buying a plan for 2021 through the Affordable Care Act. Those plans are on sale right now. You can enroll, and it is a contract between you, the insured, and the insurance company. Now, as long as you pay your premiums, you should have insurance. And if they're selling you a plan for 2021, hopefully it will continue. But the bottom line is we actually really don't know what could happen if the Supreme Court actually strikes down the ACA. I do know this, there is no off switch for the ACA. It's going to take a long time to unravel. So I'm really trying to get folks to understand that right now you're entering into a contract with that insurance company for the next year, and hopefully that would be honored by the payer as well. Back in the good old days, if you had insurance, oftentimes it was fee for service, and the provider of the service would submit a claim to the insurance company, who is the payer of the services provided. And that still happens. And we see less of this thing happening where you might pay out of pocket for services and then send supporting documentation to the insurance company and get reimbursed for the medical expense. Where we do see that kind of care happen is in the mental health world. So a lot of mental health practitioners who do therapy, substance use treatment, things like that, they have very, either they're not in network with most insurances, or they have just a couple insurances that they work with. They have to get credentialed with every single plan. And as a private practitioner, that's a pretty huge undertaking. So most therapists are called out-of-network providers, and they will have you pay out of pocket and then give you supporting documents to submit and get reimbursed in that out-of-network category. I always press the wrong button, sorry. So really basic reasons of why we have health insurance, because accidents and illness happen all the time. And even if we think we are the healthiest, most fabulous, put together, it's never going to happen to me, it does happen to me. And we're certainly seeing that right now in the midst of the COVID-19 pandemic, like folks who don't expect, I don't have any pre-existing conditions, and they get really sick. So they happen all the time. In this country, medical debt is the #1 cause of personal bankruptcy. I think that's a really sad statement about the current state of healthcare in the United States. Insurance also helps us to have access to networks of doctors and hospitals as a group and negotiates lower costs with insurance companies. And it acts as a safeguard for our quality of life, physical and financial well-being. And I should have mentioned too, by the way, if you have any questions along the way, please put them into the chat box and let us know. Maddie's monitoring it because I actually can't, I can see it. I just have to find it. So please let us know if you have that. So there are 4 main types of health insurance, and we're actually going to do a poll here, Maddie, or at least I'm going to try.
Yep.
So I'm going to launch this poll and trying to make this as interactive as possible. And I'd like everyone to answer, and these are anonymous, so your names will not be attached to this. It's just going to show us a percentage when it's done. What kind of primary insurance do you have? Okay, here I go. I'm launching the poll. Can everybody see that?
Mm-hmm.
Good. I see some responses coming in. Great. I probably should have said too, if you have Medicare, you have a government provided plan.
Oh.
All right. We have 4 who haven't voted. That's fine. If you want to get your last minute, there's another one. Anyone else want to get one in? Okay, great. Really interesting results. I'm not surprised that more than half of you have Medicare, and the other large percentage is that you have an employer or union plan. Private plans are going to be, and I'm going to share these results with y'all. You can see them. Can you see those?
Mm-hmm.
Maddie, I have a message that Alfred is in the waiting room. And Grace, if you wouldn't mind muting yourself, that would be great. Thank you.
Sure.
Oh, thank you.
There we go.
Okay, so thanks for sharing and indulging us with these polls. So fascinating. So private plans are, yes, you can call up to ABC Insurance Company and say, I want to buy an insurance plan. You absolutely can do that. And it sounds like some of you maybe have done that. Or you have an employer or union provided plan, or you have this government provided plan, which may be your VA, TRICARE, Medicare, or Medicaid, or you have an ACA Obamacare plan. So I really start in this education piece with making sure that everyone learns how to speak insurance. It is another language. I hate to say that, but it is really important that we learn to know what these things are that these insurance companies are talking about when they're talking about costs of care. So number 1 is copay. Most of you, unless you have a red, white, and blue Medicare card, can look on your insurance cards, and it usually has a fixed dollar amount there on the card that says this is what you're going to pay when you go for an appointment, maybe a procedure, or to the emergency room. So for example, my insurance card, my primary care office visits are $20, and it says that right on my card. Your coinsurance is a completely different thing. And I think this is oftentimes where folks get a little bit caught up in understanding the difference between copay and coinsurance. Coinsurance is a cost sharing amount that you pay as part of your coverage. So for all of you who have Medicare A and B, that is called an 80-20 plan. That means that Medicare pays 80% and your coinsurance is 20%. Then we have the maximum out of pocket, or what I like to call the MOOP. This is the maximum that you will pay during any benefit period. This also might be called a stop loss. Now with Medicare A and B, there is no maximum out of pocket. So if you just have Medicare A and B, your 20% coinsurance is your 20% coinsurance for everything forever. With Medicare Advantage plans, we absolutely see the maximum out of pocket. We also see this in commercial plans and employer-sponsored plans as well. Do we have any questions, Maddie?
Nope.
Okay, great. So it's really, really important that you know what your maximum out of pocket is. I think that I have a poll for that. I do. This is easy. True or false for 2021? Do you know what your maximum out of pocket is? Okay, thank you. Sorry, I was muting a few people. Thank you all for answering. So for the 8 of you, I'm going to end this poll and share the results. Again, this is anonymous. For the 8 of you who don't know what your MOOP is, that is your homework assignment for today. And I will also tell you that when I did this for the Waldenstrom's group last Sunday, I had about 65 people on the line, and more than 60% of them had no idea what their MOOP is. So I'm proud of this group because I know they've come to my talk before and likely have been checking on this information already. So for those of you who answered no, I don't know what my MOOP is, it's your homework to find out. And if you need help finding out, please let me know. So just a few more terms. Premium, that's what you pay monthly for your insurance plan. And for those of you who have Medicare, you've paid into your premium for Part A if you've paid Medicare tax. If you haven't paid enough Medicare tax and you don't have enough quarters, they have other levels of premiums that you may have to pay. You also have to pay a premium for a Part D plan, a drug plan, and you may have a Medigap plan, which you also have to pay a premium for. So there can be multiple premiums that you pay per month. The deductible is the amount of money that you pay before your insurance starts to cover your healthcare costs. And I already talked a little bit about cost sharing, but this is actually the total of the contribution you pay towards your healthcare costs out of your own pocket. And that includes deductibles, coinsurance, and co-payments. It does not include your premiums. So oftentimes your maximum out of pocket, which I just talked about, will include your deductible, your coinsurance, and your co-payments, but your premiums do not count, nor does usually a care that is provided by a non-network provider. Also, prior authorization. This is approval from a health plan that may be required before you get a service or even fill a prescription. So I'm sure many of you have been through this before. In the cancer world, certainly the biggest test I think that requires prior authorization is the PET scan. Most insurance companies don't like to pay for that one, so oftentimes it requires it to get pre-authorized. I definitely encourage you for any procedure you're having, before you get in that CAT scan or that MRI or have those labs drawn, be sure you're asking if there's prior authorization or pre-auth or pre-certification required. Because if there is, and that hasn't been done, and that's usually done by the provider's office, that can come back to you and you could be billed for the entire procedure. So I had an MRI a few months ago, maybe a month ago now, and I got a prior auth letter from the insurance company the day after I actually had the MRI. So it just goes in an example that I didn't even follow my own advice. And I got in that MRI and thinking, it'll be fine. And thankfully it was, but I really should have checked it before it happened. Okay. Also, something that's really important to know is, what is your benefit year? Does your insurance run on the calendar year, like Medicare or ACA plans do? On the fiscal year, so my insurance through Penn Medicine begins in July and ends June 30th. Or is it tied perhaps to your employment date or another date with your employer? It's really important to know when things start and end. For folks who have a calendar year plan, this is always a tricky time of the year. So I'm working with a couple of folks in my job on the helpline with people who were just diagnosed with cancer, and they have their maximum out of pocket for the year, which is like, say, $5,000. And guess what? The year starts again January 1st. Their deductible is due. It's another $5,000 maybe. And so like getting sick at the end of the year can be really challenging. And it doesn't matter when the end of your year is, but you could have a lot of out-of-pocket expenses based on when you're incurring costs throughout the course of the benefit year. You also want to familiarize yourself with your insurance's denials and appeal process. So an insurance company can deny a procedure or a test or any kind of service that you've gotten from a healthcare professional or that they want to order. So like, let's go back to that example of the PET scan. The insurance company could deny that prior authorization, and then your provider can go back and appeal, meaning that this is a request to the health insurance or the plan to review the decision or the grievance again. And there are multiple levels to appeals, and oftentimes appeals are also very successful. Also important to know is your formulary, and formularies can change throughout the course of the year. And drugs can also move up and down in the level of tiers that they may be in. So for example, maybe a drug goes off patent and then it is dropped to a lower tier. Maybe it was a tier 4 and then it goes off patent and a generic is available and it becomes a tier 2. And that can happen at any point of the year. So it's important that you're checking your formulary regularly and making sure that you know if your drugs are on formulary and if they are covered by your plan and if they are tiered or need step therapy. And step therapy means you get a lower costing drug in the same classification before they will improve you for the next one. So right now is the really important time of open enrollment. And sorry, just making sure that I haven't skipped a poll. I didn't. So open enrollment for anybody on Medicare runs from October 15th to December 7th. So you still have a few more weeks. And the ACA plans from November 1st to December 15th. Now, in some states, including the state of Pennsylvania this year, we have our own exchange for the ACA. So our open enrollment is actually open into January. The same goes for New York, California. They have longer enrollment periods for the Affordable Care Act because they run their own health insurance marketplace. With Medicare open enrollment, there are only certain things that you can do during this time, okay? You can purchase a Medigap plan or change your Medigap plan or supplemental plan. Same goes for Part D. You can enroll in Part D or change your Part D drug plan, or you can enroll or change into a Medicare Advantage plan. You cannot switch from Medicare Advantage to regular Medicare during this time. And so those are the things to really remember. If you have a Medicare Advantage plan and you don't like it, or you want to go back to regular Medicare, you need to do that during the Medicare Advantage enrollment period, which I'm going to talk about shortly. So these are just an important list of what to consider during open enrollment. I encourage everybody to really take stock of the bills that you've gotten in the past year that illustrate the gaps that you have in your coverage, and ask questions like, will making a change help to fill these gaps or potentially even create new gaps? You want to really think about what you've had done, what's covered, what isn't covered, and how much might it cost. And of course, I know you don't have a crystal ball. We don't know what the costs are really going to look like, but it's important to kind of take your best guesstimate and see what it's going to cost for all of these things. Also important, especially with myeloma, is what healthcare providers can I see and where can I use my plan? And I see this as important because a lot of you go to myeloma specialists, which I think is awesome, but you want to make sure that those are covered as well. It's also possible that you could miss open enrollment, and this really goes for employer-sponsored coverage. It is possible that you could trigger something called a special enrollment period by having a certain life event like a marriage, divorce, birth of a child, that may make you eligible to buy outside of open enrollment. It's very employer specific. Every employer has a different rule about what equals a certain life event. So you'll want to check if you have an employer plan with your HR office specifically about if you have a life-changing event that allows you to make changes to your insurance. If you have Medicare and you have a Medigap plan or a Part D plan, and that plan closes up shop, decides not to offer services in your area anymore, you would be able to make changes at that time. Like I said earlier, you can't join a Medicare Advantage plan outside of open enrollment. You can only do it during this time. You may be able to buy a supplemental or a Part D plan outside of open enrollment, but your costs may be higher. And finally, with ACA plans, if you experience, again, that qualifying life event, you may trigger that special enrollment period. And this happened a ton this year as a result of COVID-19 with folks who lost their insurance. That was a qualifying life event. And so we had a lot of people enrolling in the ACA plans throughout the course of the year since the pandemic began as a result of losing their employer-sponsored coverage and also not being able to afford COBRA. or their employer went out of business because of the pandemic and COBRA wasn't offered. So the ACA really was a great safety net for many, many people during the pandemic. And I've talked to lots of cancer patients who got saved by the fact that they could buy an ACA plan at this point during the pandemic. Okay, just gonna check and see.
So Christina, there is one question when you get to the talking more about drug plans. Cindy,
Yep.
Curious about whether a drug can come off of a formulary during the benefit year.
I think so. And I think I have seen it as well. They can sort of make, just because drugs become available or there's new warnings on drugs throughout the course of the year. So oftentimes, say a drug had an adverse event or a black box warning issued and the payer says, nope, we're not gonna pay for this anymore. It can come off formulary. Just like new drugs are approved and can be put on formularies at any point of the year. And I did have another poll that I wanted to do, if that's okay.
Sure.
Which was true or false. I know if all of my providers are in-network providers. So I'm going to launch that now. Great. Most of you do know that your providers are in network. I kind of did a trick there though and said all of my providers. And sometimes, and I have seen this happen, you have a bone marrow biopsy and the person who does your bone marrow biopsy is in network, but the pathologist who reads the results is not. I actually have seen that happen. So you have to make sure that you don't assume that just because you're getting all of your care at one facility means that all of those providers are in network with that. So you want to be sure that you're asking questions. I'm working with a client right now who's treated at a facility over in New Jersey, and the radiation oncology at that hospital is run by one health system, and the medical oncology is run by another. And she has a Medicare Advantage plan, and the medical oncology is out of network and the radiation oncology is in network. And she had no idea there was a difference because she just thought she was getting all of her care at one place. So really important to ask those questions. Okay, Kim is asking, can I get a copy? Yes, I will make the slides available to all of you. Mike can help us with getting that up somewhere on the website. I'm happy to share that with you.
Yep,
All
we'll
right.
put them up first chance.
Thank you,
Thanks.
Mike. Okay, so Medicare Part A. I'm going to move kind of quick through this, but I have some more resources I'll share at the end so you can take a little bit of a deeper dive into things. Part A covers anything that is related to inpatient hospital care, a skilled nursing facility, or what we call in the business a SNF level care, hospice, and some aspects of home health care. Part B is going to be anything related to outpatient services, including chemotherapy and radiation, unless they're provided when you're an inpatient in the hospital. So it's really, really important if you're coming up on your Medicare eligibility that you enroll in Part B. I spoke with a client 2 nights ago who didn't want to pay for Part B. He's been on Medicare for 4 years and now he has cancer. And he has no coverage for any kind of the chemotherapy or radiation that he needs. And there are special rules about when you can buy Part B if you didn't when you were first eligible. And he can't do that until between January and March, and it doesn't become active until July. So we've now got this window that we're working in between now and July when he's going to have coverage for his chemotherapy. And we're kind of scrambling because we're not sure what we're going to do. Also covered in this space are preventive care services, some chemotherapy medications that are taken by mouth. I should be more specific in that point there on the slide. There's a listing of about 10 medications that are available in both a by mouth format and also by IV. If they're available in both formulations, they're covered. If it's the PO medication, the by mouth medication, it's covered under Part B. And I've definitely had patients who've taken a prescription for one of those drugs. An example of one, perhaps that maybe you guys know, is melphalan. Melphalan is a drug that is used a lot before stem cell transplants. It's an IV drug, but it also has a by mouth formulation. And I had a patient who needed the by mouth formulation. The doctor gave her the prescription. She took it to the pharmacy and it was denied because the pharmacy also didn't know that it was covered under her Part B and they needed to bill it that way. So I do have a magic cheat sheet somewhere, which I can share with you, that shows all the drugs that are covered this way. But it's an important thing to know. And oftentimes we have to educate the pharmacists ourselves.
Christina, is Dex one of those?
No.
But it's
I know.
Okay.
Even though I know you get it IV and by mouth, it's a pretty, it is not included in that magic list. And I'm not sure why. And there was a new drug that was just approved that is also not a myeloma drug that is also not in that list. So again, I don't know how the rules get made, but it's just sort of interesting for me to see. I thank you, Mike, for that question. Okay, I'm just seeing a couple other questions here from Elvis. Hi, Elvis. What to do if different providers from one service are in or out of network? I certainly would have a conversation with the financial office or the billing office at the facility. It's possible that there is another, say, pathologist or radiologist at that facility that is in network with your insurance, or talking to them about potentially bundling the care under one of the providers and billing the insurance that way. But you definitely have to do some homework in that piece. Is it typical our primary doc can tell me in advance if the providers are out of network? Ames, I'm going to say no. So I'm going to read Ames's question to me because he sent it to me privately. Confirming all providers are in network. Is it typical the primary doctors can tell me that in advance? My experience is the primary doctors, and actually most doctors in general, don't have any idea what network they're even working with. It really goes down to the business or financial offices that are tied to those practices. So I'd ask to talk to financial services. I'd ask to talk to someone in billing and find out specifically if things are being billed under the right network. Okay, I think that gets me caught up on questions.
Yep.
Okay, I'm gonna keep moving. Medicare C, which is a Medicare Advantage plan. So it is a type of health plan offered by a private health company that contracts with Medicare. And this is the easiest way for me to put this out there. If you elect a Medicare Advantage plan, you are selling your Medicare to another insurance company that is a private provider. And yes, the commercials are true. They have to provide you with the same services that Medicare offers you. And they sometimes provide you with extra services as well. And you'll see this on the commercial. I was so excited that the election commercials were over with a couple of weeks ago. And now all I see are Medicare Part C commercials, and it's making me bonkers. So yes, you may get services like vision, dental, home delivered meals, delivered medications, transportation to your medical appointments. This varies from plan to plan, and as well as what kind of plan that you select. But what they don't tell you, and this is my biggest word of caution with Medicare Part C plans or Advantage plans that are not employer tied. And I know we had somebody in the past who had one of these, and I'm not sure if she's here today. She had an employer related managed Medicare. But if you are electing a Medicare Part C plan, and you're going through, say, Medicare.gov, or you're calling one of the numbers on the commercials that you see, Medicare Part C plans cover you just like traditional Medicare does, 80-20. So you could be responsible for 20% of your care. But what's nice about Medicare Advantage plans is they do have a maximum out of pocket. But that maximum out of pocket can be up to $7,500 a year. And I don't see that ever told to people on a commercial. So what that means is you're responsible for 20% of your care, until you've paid the maximum out of pocket of $7,500. And that is for every year. And you cannot buy a gap plan despite the fact that you have a gap in your insurance. So that's why I tend to call these Medicare disadvantage plans, especially for folks with cancer. And it's definitely not something I recommend, because the other side of it, and Richard, I'm going to speak to you because you asked me a question offline before we went into this. The other thing is that you sold your plan and it's hard to buy it back. So there are specific rules, again, about when you can disenroll from a Medicare Advantage plan, which is from January 1st to March 31st every year. You can disenroll and go back to Medicare Part A and B, but you still need to then buy a supplemental plan, and they may charge you more for that supplemental plan because of a pre-existing condition and because it's outside of your open enrollment time. So I just want to make sure that everybody understands sort of the fine print. The other thing that I see is they say $0 premiums. Yeah, that's true. You don't have to pay more for this type of plan. Those, for some plans you do. You still have to pay your Part B premium monthly that comes out of your Social Security. These are also typically managed plans, which means you have to choose a primary care provider who's the gatekeeper, who gives you referrals for specialist care. And the other thing that I really see, and this is another thing that really affects cancer patients with Medicare Advantage plans, is that the copays for specialist cares can be much, much higher. So for example, you may have a $70 or $75 out-of-pocket, copay for every time you see your oncologist. Versus Medicare, they don't make a differentiation between if you're seeing a primary care doctor or a specialist when they're doing their out-of-pocket expense for your doctor's appointments. So that's regular Medicare. Does that make sense to everyone? I know it's kind of confusing and it's a little bit challenging. Yes. And Suzanne, thank you for commenting. These networks can be super restrictive. You're 1,000% correct. One of the challenges is also that they tend to be geographically based. So while you may elect a Philadelphia plan because you live in Philadelphia and your in-network providers are in Philadelphia, say you're traveling and you're in Denver and there's no in-network providers in Denver and you have a medical issue, you're going to be paying those out-of-network costs. And that is a key difference with Medicare. So Suzanne, thank you so much for pointing that out and reminding me to say that important piece.
Christina, can you, because of going back to your former point about the disadvantage of Medicare Advantage plans, not making it easy to buy back your regular Medicare plan, can you, if somebody finds themselves in a position where they have an Advantage plan, they realize that it's not the benefit they had hoped and want to go back to traditional Medicare, what might be a path they could take?
So that's when they get into that special disenrollment period, which is January to March. And you would have to contact, I believe, Medicare directly. I can look that up for you guys though, because I have not had that specific question before, Maddie, about how you disenroll. Also, like if you disenrolled, say January 1st, your Medicare would likely be back to eligibility on February 1st. So then again, like if you disenrolled from your Advantage plan February 1st, you'd have quote unquote straight or regular Medicare March 1st. So there will be a little bit of a transition kind of lag time, but I'll look that up, Maddie, and be sure to find out how you do that. Okay. Elvis, I agree. He says, why would anyone want Medicare Advantage plan, lower cost, but much higher risk? Agree completely. And I'm not sure if you saw on a previous slide, I did ask a question of, are you risk averse or risk tolerant? And I think that's a really important question to ask yourself when it comes to the business of insurance. I am super risk averse, so I'm going to have the best possible plan I could have. I'll pay more upfront if it means on the back end, if something happens, and that's the big thing I focus on. If something happens, I know that I'm going to have less of a cost on the back end. So it is kind of like throwing the dice. And certainly I will tell you, like when my parents turned 65, I definitely counseled them against this type of plan. And we're now 10 years into my parents having Medicare, and they're very happy with their Medicare A and B, their GAP plan. And luckily, my dad was able to keep prescription coverage through his former employer, which also really kept his prescription costs much lower than with Part D. So things to really consider going forward. Looks like we got some more comments.
No, just echoing the more just details of the disadvantages.
Okay, and then Ames also.
Oh.
Ames, you're killing me. Can you please review the difference if the Advantage plan is employer sponsored or not? So a lot of employers, you know, instead of switching from that kind of traditional pension sort of affiliated healthcare, a lot of employers used to keep retired employees on insurance in some way. Many of them switched to offering managed Medicare plans like Part C, and they pay into it a certain amount for their retirees, so their benefits may look a little bit different. But again, that varies from plan to plan. So if you're a retiree and they offer you this type of plan, I would definitely tell you, you got to read the fine print. You don't have to take it though. Okay, now we're going to get into the good stuff, and I really do want to get to this because I know a lot of you have questions about Part D, and this year I discovered a really cool tool that I want to show you how to use in Medicare.gov. So D is your prescription drug coverage, and there are these impossible to understand who actually came up with this format for how we pay for drugs in Part D. And I will tell you, and I just want to highlight that one major impact of the Affordable Care Act on Medicare was the closing of the donut hole with Medicare Part D. So just want to make sure everybody understands that if the ACA is struck down, that potential massive donut hole, which I know you guys are all dealing with the donut hole. The difference is here, I don't know if you can see my pointer. Mm-hmm. What the member pays, what the plan pays, and the pharma discounts. This is what could go away, the pharma discounts, if we lose the ACA in this space. So that means your drug costs are going to go up even more potentially. So I, this year, discovered, and I just want you to bear with me. And you understand that these slides are a little bit small because I had to do screenshots off of Medicare to highlight this for you. But if you go to Medicare.gov, which is actually, in my opinion, one of the best government websites that there is, and you go to Part D coverage, and then you go to costs for Medicare drug coverage here, and then on the bottom, really small, it says, look for specific Medicare drug plan costs. You want to click on that. Okay. Mm-hmm. That will bring you to a page that looks like this. You can log in or create an account, but if you just want to shop around, you can say continue without logging in. You can also look for Medigap plans in this same tool. Then you'll answer a few questions. So when I did this, and I'm just going to tell you, I used me as an example. I'm looking at 2021 plans, and I'm just looking for a Part D plan, okay? And as you can see, these are all the plans that you can look at using this tool. I then put in my zip code. Again, I'm looking for a drug plan. And I also answered that I don't get help from any of these programs listed above. This is probably a whole different webinar that I should do at some point. So I'm actually not going to cover Medicare savings programs and extra help much today. But I can do that in the future if you're interested. Do you want to see your drug costs when you compare your plans? Yes. And I then encourage you to do a comparison here of a retail versus a mail order cost. So you can say both, and then you'll need to tell them the pharmacy to get the most accurate drug costs. So then I put in the magic drug that you are all, many of you I'm sure are on or have been on at some point, Revlimid, add drug, done adding drugs. Again, my zip code, I chose some pharmacies. And this was the plan that came out to be the cheapest, this Clear Spring Health Premier RX prescription drug plan, which would cost me $13.60 a month for premiums. And this is the lowest price plan that came up with the lowest priced for Revlimid. And yes, my heart stopped when I saw that. Just to give you more of a breakdown, you can see then 25 milligrams, that's the dose that I put in. This is the retail cost, cost before deductible, cost after deductible, cost in the coverage gap or donut hole, and cost in the catastrophic plan after the coverage gap. This plan website also shows you you'll meet your deductible in January, you'll be in the coverage gap in January, you'll exit the coverage gap in January, which also means you're in catastrophic coverage for the rest of the year. And then it also breaks down how much the drug will cost you every month for the rest of the year. Is everybody else having chest pain right now? I hope I'm not making everybody freak out. But I think it is a really good tool to help you understand the impact and the possible out-of-pocket expenses that you're going to have associated with Revlimid under Part D. Any questions there? Or is everybody just
We're sort of numb.
I know, me too. So the good news is that there is help available. I mentioned a little bit earlier, extra help or low income subsidies and dual enrollment programs. These are for folks who are lower income, and there are definitely different levels of these that are available to people. If you want more information on this, absolutely let me know, and I can talk with you more about this individually. Also, there's state pharmaceutical plans for folks who are, at least in Pennsylvania, you have to be over the age of 65. That's called PACE and PACE-NET. And again, they have income requirements as well, but these can be a great, this is funded by the lottery. So anytime you see Gus, the second most famous groundhog in Pennsylvania, showing you how to go get your scratchers, those scratchers are funding PACE and PACE-NET programs, which can really help lower the cost of prescription drugs for eligible seniors in Pennsylvania. In New Jersey, they have a program called PAD, which is very similar, except that it also covers people who are disabled. And in Delaware, they have a plan called DPAP. Every state has varying prescription drug plans. I was working with a client in Florida, and his plan was terrible. Like, they offer very, very little. The plans in Pennsylvania and New Jersey in particular are actually pretty generous if you can get onto those programs. There's also copay assistance, and I did have a poll for this one because I know many of you are familiar with this. And I'm going to launch this right now, which is yes or no, I get help from Copay Assistance Foundation. So if you can answer that poll.
Is that for 2020 or 2021?
Well, I don't, and it's weird. It stopped answering. So please answer again if you haven't. Everybody has sort of a different year associated with their copay assistance. So because it's usually based on when you apply, not the calendar year. So I'm just asking, like, if you've gotten assistance in the last, let's say in the last year, you've gotten assistance from a copay foundation. I don't know, it keeps restarting the poll. I'm not sure the polling is working right. But I did see a fair number of you who said you did not get assistance from copay assistance.
Well, and I think with a question like this, Christina, sometimes we don't generally ask people if they're getting copay assistance, so it could be a reluctance to answer.
No, it actually kept reloading, Maddie, for me. Like, it would
I
start
see.
it over again. I got like 3 different response pages. So, and I should have said again, like, it just launched it again by itself.
Yeah. So
it's literally like polling being crazy. But I wanted to just highlight that there's actually a number of programs available for myeloma to help folks out. See, it just launched again. This is one of my, Zoom issues. Excuse me. I know a couple weeks ago, the LLS fund closed. It is open again. The Healthwell Foundation is currently open. Sorry, a little bit of a dry throat. And the Patient Advocate Foundation is currently open. And these other 3 organizations, the PAN Foundation, Good Days, which used to be known as the Chronic Disease Fund, and Cancer Care also all have myeloma funds, but they're currently closed. So just to give you also a little bit of just myeloma is what I call a well-funded copay program disease. When I did this talk for the Waldenstrom's group last week, I had 2 options to give them, and they were limited as well in terms of how much assistance that they provide. So every fund works differently in terms of who is eligible for them, as well as how much funding they provide and what medications and or premiums that they may cover. So the LLS is definitely by far the most generous in terms of they will cover premiums for your Medigap plans. They will cover your copays, your coinsurances for treatments. And I had to talk to a myeloma patient earlier this week who LLS closed and they were covering her for Iridia, but then they closed and she needed more funding. She went to HealthWell and Iridia was not included in their list of approved medications. So just to give you an example of the granularity of how these funds can differ. And the eligibility in terms of income is for these funds, I believe for all of them is 500% of the federal poverty limit. So Kim, you asked, do all have income limits? Yes. 500% of the FPL, as I call it, is around $61,000 for a household of 1, and then it goes up from there. I can give you examples. I can provide you with the chart of what eligibility is. And Cindy, great question. Can you have assistance from more than one fund? I have not seen anybody be denied if they have assistance from one fund and they've exhausted it, because we just looking at that chart of how much Revlimid costs, you're going to exhaust an LLS fund within the year. So I've definitely seen people who've had assistance from more than one foundation. And Mike is very funny. He said, dry cough is a COVID symptom privately to me. And I'll just tell you, Mike, I'm healthy. I haven't been out of my house in a week because my parents are coming in 2 days. And I have the space heater on and it's making it very dry in my room. But thanks for your concern. And I'm safe and sound. Thank you very much. You're so cute.
Christina, I'm happy. I'm glad that you're safe. Can I add one little thing about the assistance limitations is that one of the things we keep telling the group members is for you not self-select out thinking you're not eligible for any of these funds based on what your read is of your income. Apply if you're in the remote terrain of the 500%. There's quite a lot of leeway.
And I've had people who've gotten approved because they had like $2,000 in outstanding bills and they were just over the income limits, but those bills would have taken them under the income limit. So I agree. I echo that, Maddie. Just even if you're a little bit over, it's still worth applying. And especially if you've got some outstanding medical bills that we can kind of offset some of that and get you in that category.
So John Oliver adds that Celgene has a plan if your income exceeds the HealthWell Foundation limit.
So there's some nuance to that as well, because it has to be a certain percentage over of your income. I'm going through this battle right now with another drug company because the drug that she needs is more than 50% of her monthly income. And there's no copay programs open for her cancer, which is a thyroid cancer. And she doesn't qualify for their non-Medicare patient assistance. So we're fighting now about what is the acceptable amount for a pharmaceutical company to ask an individual to pay in terms of percentage out of their income. And also with Celgene, and I get nervous about this because there are very specific guidelines about financial assistance provided by pharmaceutical companies to people with Medicare. And that's actually one of the things, and maybe, I think it's in a slide I have coming up. So let's hold on to that, right?
Christina, before you there's another question about these financial help services being retroactive if it takes too long. So I think they will have a look back.
Some of them have a look back. It varies from fund to fund if they have that and how long they will look back. So you definitely should ask that question as well. It's a great question, Suzanne. I had a patient who was approved for LLS funding in February and didn't realize that she could use it. She was just using it for premiums. She didn't know that she could use it for her office, for her chemotherapy as well. But because she was approved all the way back in February and then had been accumulating bills, we were then able to use it. It's not quite the same thing. So she was approved earlier. But I mean, I just want folks to understand the depth of things that could potentially be covered as well.
And the process of being approved or not approved does not take very long.
It does not. It can be very, very quick, especially if you've got all your documentation in a row. There's a portal to use for most of these organizations. And I have to be honest with you, I've been working with HealthWell a ton because they offered a COBRA assistance fund during COVID. And I got a ton of patients on that were able to help pay their COBRA payments. And they've just been amazing to work with. So, but I did want to differentiate also that copay assistance is not these copay cards. Again, you may see commercials from certain medications that say you may have a $0 copay. Those are for people who have commercial insurances or even ACA types of plans. They're eligible, but anybody with Medicare or Medicaid or veterans are not eligible for those copay cards from the pharmaceutical company. And again, that has to do with the rules regarding Medicaid reimbursement and pharmaceutical companies, which is something a lot of people want to change. And again, this goes back to the ability to negotiate drug costs with Medicare, which we don't have right now and we need. So Cindy is also offering that it's important to keep your account active with LLS or they will close it. Great point, Cindy, and don't wait to submit your bills. Cindy, excellent point. Anybody else with any tips or tricks who've been using LLS for copay assistance, please put them in the chat box so we can share. Just really briefly, employer and union plans. Several of you did indicate you have this kind of insurance. It's clearly tied to your employment. What's nice is that the employer and the employee typically share the cost of the premiums, and the plans are dependent on the contracts negotiated between the employer and the insurer. And that's an important point to remember too, because if, say you're having trouble and getting the care that you need at a specific provider, I've had lots of employees who've gone back to their employer and said, this plan that you had us all enroll in, it stinks and I can't get what I need. And then had the employer call up to the insurance company and say, if you're not going to offer these services that are part of our contract, we're going to go somewhere else. So it can be an important negotiating point there. We are seeing some really interesting trends in the private insurance space, or I'm sorry, in the employer insurance space, which include higher premiums, higher cost sharing, and this really somewhat challenging trend of high deductible plans. So we're seeing that while the front end cost, again, the premiums may be really low for the employer and the employee. There's now, I've seen deductible plans of up to $10,000 or $12,000 a year for an employee. So I'm telling folks to be sure they're reading the fine print and really understanding what having a high deductible plan needs. My sister is in a high deductible plan and she just had a ton of medical stuff done, but she had actually also had a healthcare savings account where she socked away money, the entire amount of her potential high deductible she had in that account, which was also tied to her taxes, and was able to use that money then to pay for her deductible. So there's some ways that you can work in that space. Okay, good. Medigap plans, mentioned these earlier. These are supplemental plans that cover that 20% gap that is not paid for by Medicare A and B. These are sold by private companies, and this is like the one insurance that is not covered for pre-existing condition clauses under the ACA. So they can charge you more if you have a pre-existing condition for a certain period of time. Usually it's the first 6 months of your plan that they will say, we're going to charge you more of a premium and or we're not going to cover costs related to that diagnosis for the 6 months, the first 6 months of your plan. This is my handy dandy little chart. This is not the same as Medicare A and B. This is a chart of the Medicare supplemental insurance plans. And because we're not creative enough to come up with anything different than another like alphabet thing, these are called these different types of plans. I know many of you in the past, because I have been giving this talk to you guys for at least 6 or 7 years now, were in Plan Fs or Plan Cs. After 2020, these plans are no longer offered because the federal government decided that the paying of this Part B deductible was actually not okay. So if you have these plans, you can keep them. They're just not sold to anybody else beginning this year. And as a result, the pool of folks who are insured with Cs and Fs is getting smaller. So we may see those premiums go up. The major difference, and I've really counseled a lot of people into thinking about either a D or a G plan. You can see that doesn't cover that Part B deductible, which is here $183 per year. Okay, G covers the excess charges versus D, which does not. And when you go on that tool, which I showed you for looking at the medications, you can also search different plans for Medigap in your area, and it will show you Medigap Plan A is $57 a month. Medicare G is $280 a month. And I'll tell you, I know a lot of people have sticker shock and they think, I can't possibly afford another premium monthly. And I think that's why those Medigap or Medicare Advantage plans are so attractive to people, because they're like, I don't have to pay anything. But if you need care, you do. So again, it's really about balancing. Do I want to pay more upfront and less on the back end? Or am I okay with paying less upfront, but know that I could get a big sticker shock when it comes, like if I get sick? So something to consider when thinking about those two, weighing those two things. That's great. Suzanne loves hers. And I know a lot of people have really good Medigap plans. I think they do a good job. Really important to pay attention to when you can buy a Medigap plan, though. As I mentioned about the pre-existing condition clauses, but it's the best time to buy is during your initial enrollment period. This begins the month you turn 65, and you have to elect Part B. And that continues for 6 months after that. And they cannot use medical underwriting or charge higher premiums during that initial enrollment period due to pre-existing conditions. Then, as we mentioned earlier, right now we're in this annual open enrollment period from October 7th to December 7th. This is also a time that you can purchase a plan. But if you didn't have coverage before, and so maybe you're not switching a plan, you just want to buy for the first time, they can look at those pre-existing conditions, just the same for during outside of enrollment periods as well. So great. Now, here's a little caveat as well. For those of you who are under 65 and are on Social Security disability for 2 years and then go on Medicare, federal law does not require insurance companies to sell Medigap to individuals who are not 65. Some states do require it. It's really state to state, but they can adjust premiums based on your age. This is also another reason that I'm seeing a lot of younger folks on Medicare who might be drawn towards that Medicare Advantage plan, because they do tend to enroll some of the younger folks as well. But then they're really stuck because maybe they're 55 and they enroll in a Medicare Advantage plan because they can't buy a Medigap plan, and it's just they have that MOOP. So they know, okay, I'm only going to pay this maximum every year. It's really a catch-22, I think, for some of the younger people who are on disability. And then this is also about if you have coverage through work. And one of the first questions we had earlier was, is Medicare a secondary insurance? The answer to that question is sometimes it can be. If you or your spouse are still working and have coverage through your employer, but you're also eligible for Medicare, you could have that work or union coverage as your primary, and then Part B would be your secondary insurance. Because you have all of that coverage, you may then say, I'm not going to elect Part B right now because I really don't need it. And that's an important thing to think about, because if you do at that time elect Part B, you have started your initial enrollment period. And so unless you buy a gap plan during that, you could have those higher premiums outside of your open enrollment. So it's really important to maybe not start that open enrollment period if you have coverage through your employer and are using your Medicare Part A as a secondary. Hope that answered your question. Just trying to keep an eye on time. Real quick about the ACA. We did get away from the letters, at least, for the kinds of plans that are offered with the ACA, which are platinum, gold, silver, or bronze. These are sometimes referred to as the metal levels. And with these, you have very similar. Silver is set up like Medicare, where it's an 80-20 plan. The monthly cost in terms of your premiums is lower than it would be for a gold or platinum plan, but higher than it would be for a bronze plan. If you have a platinum plan, that's a 90-10 plan. I should have said the gold is 80-20, the silver is 70-30, the bronze is 60-40. There we go, got it right. So again, I tell folks, and if you want to get an ACA plan and utilize tax credits and or cost sharing, you have to buy at least a silver plan. These plans differ like a lot of these other things we've talked about already in terms of out-of-pocket costs, the networks, and prescription drugs. And one of the things I like to highlight when I do this talk is that some ACA plans have a separate deductible for pharmaceutical and major medical. And that is a plan I would stay away from, because then you could have like a $5,000 pharmaceutical deductible and a $5,000 major med deductible, and that's a lot of money. This is just a short list of who can buy, because I wanted to get to this in terms of the 2020 Supreme Court case. So this case is really based around the individual mandate, which actually stopped. And the individual mandate was the tax or the penalty that was assigned to folks if they did not have health insurance. And that was already something that during the tax law changes put in by the current administration, I guess 2 or 3 years ago now, that was taken out. And so there is no more individual mandate beginning in the year 2020. So there's no more penalty or tax related to not having insurance. And in Texas, they said, well, if there's no mandate, then the entire law can't stand. It's unconstitutional. It's a little bit scary that they got to that space, but I went to this great webinar probably about 6 weeks ago now, because it was before the confirmation hearings for our new justice, which is why I've X'd out option 2, because that can't happen now. But there are 3 possible scenarios of what could happen. The first being that the court rules in favor of the defendants and finds the ACA constitutional, and it would leave the law untouched. Or number 3 here, court rules in favor of the plaintiffs and finds the mandate unconstitutional. And so certain provisions of the ACA would need to be removed that are tied to that individual mandate. The thing is that most of them already have. And so that seems a little wonky to me. It's also super concerning to me that there is no tax or penalty for folks to not have insurance, because we kind of need it. And the reason is that to balance out the risk pool, meaning the number of people who are buying insurance through the healthcare exchanges, if it's all sick people and no healthy people, it can't possibly survive. It's called the death spiral of the ACA. And that's something that's actually super concerning if number 3 happens. And they hold up that there will be no consequences for not having insurance related to this. And then finally, number 4, and this is sort of the nuclear option, that the court rules in favor of the plaintiffs and rules the entire ACA unconstitutional, which would invalidate the law completely. I don't think that's going to happen, just because there's been a number of Supreme Court cases related to Obamacare so far, and it's been upheld. So precedent might be in our favor. So we'll have to see. I was pleasantly surprised by some of the dialogue that I saw coming out of the oral arguments this week. And I'm hopeful that we're still going to have the ACA going forward. And of course, hopeful that having a new administration who's actually interested in expanding healthcare options is also something I'm hopeful about. I'm trying to remain as politically neutral as I can, by the way. But I want to make sure everybody understands that what's at stake, like I said earlier, affects every single one of us. Those protections for pre-existing conditions, if that law is struck down, that goes away. And everybody in this call, and all of the 10 million people now who've been diagnosed with COVID are all people with pre-existing conditions. I don't know a lot of people who don't have a pre-existing health conditions. Also, what goes away is a ban on lifetime caps and annual caps to insurance. I definitely know that when I practiced in the hospital in the early to mid 2000s, I had several people who needed bone marrow transplants who had $1 million lifetime caps on their insurance. And that bone marrow transplant put them at that cap, which meant they had no more coverage with that plan going forward. And that was a huge issue. That went away with the ACA. It could come back if the law is overturned. Also included in the ACA is coverage of essential health benefits, which we've all benefited from, maybe through your screening colonoscopy, mammography, your doctor's visits annually every year with no copay. All of those are essential health benefits. We also would lose the ability of folks that are up to the age of 26 being able to stay on their parents' plan. We would lose the Medicaid expansion. And I just finished an article yesterday looking at some of my data as the financial navigator for the cancer support community. And 71% of our callers to me who got to me for financial navigation who did not have insurance also lived in states that did not expand Medicaid. So they also did not have that option. So that was very telling to me. And as I mentioned earlier, the Medicare Part D closing of the donut hole would also go away. So like I said, I'm telling folks that the ACA is still the law of the land. Open enrollment is open, plans are being sold. And like I said, we just don't know if the law is struck down. There is no off switch. There will take lots of time to unravel, and there will be more court cases. So sorry, Eugene decided to sit on Linus, and that was did not go well for Eugene. So when I went to the webinar that I did that unpacked a lot of this, they said that they thought it would take at least another 10 years if the law was struck down to get through all of the litigation involved with what could happen afterwards. And I might go to my lawyers in the group for thoughts there. So how do you prep for open enrollment? Know your plan. There's a great resource called the Cancer Insurance Checklist. If you Google it, you'll find it, and ask folks for help. I just wanted to put in one more slide really quickly. Sorry. Some of you may be considering things like a GoFundMe to help pay for some of your medical costs, and these things can be a huge help, but you really need to be willing and able to put it out there in this social media space to raise a lot of funding. And it can be, you got to be willing to like put your story out there, have people share it, get folks on board with helping to pay for things. There also is potential, I just want to say, not so much tax liability, but potential for public benefits liabilities. So oftentimes these fundraisers, GoFundMes, from what I've seen in the tax laws, they're usually considered gifts. But if you get a $50,000 gift and you're on Medicaid, it could throw you off the Medicaid rules pretty quickly. So just buyer beware when it comes to medical fundraising. It also, to me, is a really sad narrative that we have gotten to this point where we're so reliant on something like GoFundMes to help pay for healthcare in this country. Okay, we're almost there. I know it's 3 o'clock. Who can help me? There's probably financial or navigators or advocates at your treatment centers or social workers. There's also something called the State Health Insurance Assistance Programs, SHIPS counselors. There's navigation assistance available for the ACA. And there are also private brokers out there looking to sell insurance and to help you with understanding it. Just remember that they're trying to sell insurance. They're trying to make money off of you. They got to, pay the bills as well. So that might be a different motivator for them in that space. And just a couple of resources available to you. I'm always going to put in a plug for oncolink.org. And on Oncolink, I have a set of 6 webinars that are my health insurance webinar series. They're available for free. It unpacks all of the different parts of Medicare, the ACA, health insurance, a lot more than we talked about today. So I'd encourage you to take a look at those. It's oncolink.org/insurance is how you get directly to that. Some other really helpful websites that also might be interesting to you available here. And that's my contact information, though most of you do have that. You can get in touch with me either way. And I thank you for your attention, for your questions, for participating in some of my polls. Just seeing if we had any other questions.